Let's look into testing for a moment. What tests are essential when making a diagnosis?
So at the beginning, we clearly have to have tissue. I always say tissue is the issue. And so we may have features that are suggestive of lymphoma, and even sometimes radiologists will describe a CT scan or an X-ray and say, this looks very suspicious for lymphoma. But unless we actually have a biopsy that confirms lymphoma, we won't go as far as to render a diagnosis in the absence of a biopsy. Now, our biopsy approaches have evolved over the last few years. The gold standard, or what I would consider to be the best approach currently, is to actually have an excisional biopsy, meaning we find a lymph node that looks suspicious and we either remove the entire lymph node or a large section of that lymph node to render a diagnosis, because there's various things we need to do to that lymph node. So generally we do what's called immunohistochemistry staining. So we stain either surface markers of those cells or markers within the cell, because cancer is defined as having an abnormal clone or population of cells that all have the same features, and they're able to survive even if the host is not thriving. And so that's essentially what we're trying to define. Are there cells in this lymph node that are all the same? And what features do they share in common? And then we will also do something called flow cytometry, where we'll take these cells and essentially sort them according to those surface markers. And that will also tell us, is this a B cell clone, a T cell clone, and what features would distinguish one lymphoma from another? And the last thing that we need tissue for are what we call molecular studies, where we may learn about either genes that are rearranged or mutated within those cells that, again, may help us further classify the lymphoma and, again, group them into higher or potentially lower risk groups.
What do the results of these tests tell us about prognosis and treatment choices?
Yeah, so again, everything kind of hinges on what type of lymphoma we're facing. So, for instance, diffuse large B-cell lymphoma is what we call an aggressive lymphoma. So what does that mean? It can grow very quickly. It can take over the patient in terms of resources. So generally, patients will have weight loss and sometimes even constitutional symptoms or B symptoms such as night sweats and fevers, fatigue. In the absence of treatment, it is universally fatal. Now, that timeline can vary from one person to another, but generally within a year, if we don't treat large cell lymphoma, generally that's not survivable. But as I've also mentioned, for at least 60% of patients, and potentially even more, we can cure it with standard treatment. There are other types of lymphoma, such as indolent B-cell lymphomas, where actually the goal is not cure, but patients may actually have a normal life expectancy, meaning they will face multiple treatment courses over their lifetime, but at the end of the day, they should live just as long as someone their same age and sex who doesn't have lymphoma. So again, that's going to be a vastly different treatment course and outcome. And so sometimes when you're sitting in the waiting room and you're sharing your journey with others, you have to keep in mind that you may all be using the same term, non-Hodgkin lymphoma, but our expectations in terms of treatments and outcomes might be vastly different.